Welcome to AETCM, the emergency medicine channel. 20-year-old female, non-case of acute intermittent porphyria, came to ER with complaints of abdominal pain with altered behavior into 1 day. Initial 10-second assessment, airway was patent with no gurgling of secretion, hoarseness or stridor. Breathing, bilateral air entry present. Respiratory rate of 18 per minute of saturation of 98%. Circulation, heart rate of 100 per minute, BP of 140/80, S1, S2 present with no added sounds. Disability wise, JCS is E4, V4, M6, exposure GRBS of 181, and the temperature is febrile. Adjuvant to primary survey, we did a CBC-CRP, total counts of 7.2 with an HP of 11, platelet of 2 lakhs and CRP of 25, and ECG wise it's sinus tachycardia, VBG no acute acid-base disorder. So sample history, it's a 20-year-old female, non-case of acute intermittent porphyria, presented to our ER with complaints of abdominal pain, which was diffuse, crampy, associated with...
Tell me conditions where you get abdominal pain. Non-surgical abdominal pain. Medical causes.
Depending on the area.
Medical cause for abdominal pain. There is no
acute pancreatitis.
It's a surgical cause.
DK.
No.
MI can present.
Inferior MI. Porphyrias. These are one of the causes. One more cause.
Lead poisoning.
These are the 4 major causes of abdominal pain by medical conditions.
So here abdominal pain was diffuse, crampy, associated with altered behavior. Patient was agitated with irrelevant talk was there. Patient bystander also gave history of constipation for the past 2 days, and the urine was reddish brown in color.
Cola color.
Then no history of fever, vomiting, chest pain, palpitation, syncope, or orthopnea, or decreased urine output. On examination, patient was conscious but agitated and irritable with irrelevant talk was there. CNS wise, S1, S2 present, and respiration, bilateral air entry. CNS, there is no focal neurological deficits, and per abdomen was soft and non-tender. So since patient is already a case of acute intermittent porphyria, the patient we have to take it as an acute episode of acute attack of porphyria. Okay. So in case of acute intermittent porphyria, it is...
How do you manage this pain? How do you manage this case?
First thing is we have to start her on dextrose.
So that is the treatment. Dextrose is the treatment for acute intermittent porphyria. Painkiller can be given.
Dextrose plus supportive treatment with opioids for pain.
Okay.
And other, if some porphyria can be presented as weak.
Before giving any drug in porphyria, what else you have to check?
We have to see whether that drug is safe in the porphyria.
So that is very important. There are a lot of drugs, including convulsive therapy. Many drugs are contraindicated in porphyria. So we have to check each drug whether it can be given, whether it aggravates the problem or not.
In case of painkillers, unsafe drugs are barbiturates, NSAIDs, except paracetamol can be given. Phenytoins and rifaximin, any drugs that can induce hepatic ALAs like cytochrome P450 enzyme inducers are contraindicated in porphyria.
What anti-epileptic drugs are safe then? So this patient, epilepsy is one of the major problem. They can have seizures.
Benzodiazepines can be used.
Benzodiazepine and levetiracetam. Levetiracetam is a safer drug. Okay. So these are the 2 important areas in AIP. One is abdominal pain, other one is seizures. If you know to manage these 2 things, in emergency room, most of the things are done.
So treatment wise, we symptomatically manage the pain. Then we started on dextrose. Okay. Dextrose we given it's a dosage of 300 gram per in 24 hours. So we take 3 bottles of 100 ml 25D. That is 75 gram of glucose will be there. Plus 200 ml. Total 3 will be 300 ml plus 200 ml NS we will add. Together we will start at 100 ml per hour. For 4 cycles we use. Okay. So total of 300 grams per 24 hours we have to use.
The patient is diabetic.
Diabetic. Hemin.
Huh? You give insulin.
Insulin.
So there is no other option. You dextrose with insulin. Insulin is not contraindicated. You can give.
But the drug of choice is we can give Hemin.
It is not available.
Not available in India. In case of Hemin, its dosage is like 3 to 4 milligram per kg. IV as a single dose we can give till the attack is subsided. Dextrose then in this acute porphyria, it is actually it is due to partial deficiency of porphobilinogen deaminase enzyme. Since this is deficient, porphyrinogen and ALA will be elevated in our system, which is neurotoxic. So most common complications will be neuro and neurological complication plus neurovascular complication. So most common
Neurovascular means what?
like neurovascular
Stroke.
like weakness will be there, plus visceral organs will be affected. So most common complication is constipation, vomiting, muscle weakness, psychiatric involvement, tachycardia, hypertension. Some cases kidneys can be affected, liver can be affected. In severe cases, there will be quadriparesis or respiratory muscle depressions could be occur. So the treatment is start on dextrose and high carbohydrate diet. So precipitating factors include drugs. That is, some drugs are contraindicated. If we started on that drug, patient can go. Then alcohol, smoking, any infections, then puberty. Progesterone act as a inducer. So most commonly attacks will be more in females during luteal phase of menstruation. Then starvation or decreased calorie intake. Then psychological, any stress can also precipitate this attack, porphyria attacks. Then in diagnosis wise, we'll mostly diagnose by urinary porphobilinogen or ALA can be used.
Color of the urine is cola color.
Reddish color due to porphyrins in the urine. Then in urine porphyrinogen spot test is also there, so we can diagnose it. If we take an MRA mostly show press kind of feature, posterior encephalopathy. Reversible encephalopathy syndrome.
Visual loss can be shown.
Then dark brown color urine could be there. So in some patient, hyponatremia can be also occur due to SIDH. Then hypomagnesemia, hyperkalemia, elevated triaminase can occur. Due to hepatic ALA, there's a huge chance of patient developing HCC or cholangiocarcinoma in the future. With CKD can also occur. Then management wise,
the only thing you should know which all drugs to be avoided. That is very, very important. Especially patient come with severe like seizure episodes. That management also should know.
So, as ER wise, only thing is when patient came with an acute, we have to symptomatically manage the patient's pain, or if any respiratory depression is there, we have to manage that, or if avoid any harmful drugs. Then exacerbating factors we have to find out and we have to stop that, and calorie intake and carbohydrate intake, and treatment of any infection if it is that precipitating factor.
So
and start on dextrose.
Factor in this patient?
Patient was having decreased food intake for the past few days. So carbohydrate decrease, carbohydrate diet. Then start him on glucose, dextrose, or if it is available, Hemin can also be used. So there's a drug called Jivacitran. That is can be used to prevent the further Givosiran. Givosiran, that is prevent recurrent attacks, which can be given subcutaneously once a month. Its dose is 2.5 milligram per kg, maximum of 189 milligram we can give. But we have to monitor RFT and LFT. Most common complication of that drug is acute pancreatitis. Then complications of AIP is hypertension, CKD, hepatocellular carcinoma or cholangiocarcinoma, or increase or decrease in iron store can occur.
And what happened to this patient?
Patient, this attacks usually last for 2 to 3 days. So we started her on dextrose, that is to 300 gram per 24 hours we started, and also we started Femda infusion, which is safe for pain. After a few days, patient becomes symptomatically better. Then also high carbohydrate diet also we started.
Anything else? Okay. Thank you.
Thanks.